we're talking about the industry reaching the tipping point, and despite all of this new guidelines and the academic centers, the excellent facilities that you mentioned that are implementing these genetic and genomic insights into their workflow so patients can have this up front because it can guide clinical decisions downstream. 80% of patients are treated in the community setting, right? Where they're not necessarily specialists that see colon cancer all day, every day. They see, a myriad of cancer types that will walk through the door. And there was a paper published a couple years ago in JAMA, the Journal of American Medical Association, and it reported that in California and Georgia between 2013 and 2019, it found that germline genetic testing was still low. Um, Among more than 1.3 million patients in the review in this study, only about 93 patients, or about 6.8%, underwent germline genetic testing, according to the published findings. Men diagnosed with breast cancer had the highest rate of testing, and it was only 50%, Dr. Esplin. 38% of ovarian cancer patients were tested, got testing. Recommendations, the guideline recommendations is that all people with these two cancers receive germline testing, genetic testing. Among women with breast cancer, it was only 26%. BRCA1 hereditary cancer was launched in 1996. And this report published in 2023, only 26% of these patients in the study. Maybe it's unfair to ask, but if we did this study currently, would the numbers look any different? I guess my point is, how long does it take for patients to be able to access these innovations that come to the market?
Yeah, it's you've highlighted a source of frustration, to say the least, for me and many like me, and I think you call out a key piece there where you're noting there are those individuals, right, and currently, right, everyone with breast cancer is recommended for testing. Everyone with ovarian, pancreatic, obviously the male breast cancer you mentioned before, everyone with colorectal and uterine cancer really should be at the very least considered for germline testing and receiving this. And we're seeing, even for those where the guidelines have existed for a long period of time, the implementation has been 50% at best, which is a dramatic underutilization, and it's a huge missed opportunity for patients. And I wish I had an answer for, like, when is this going to get fixed? Clearly, myself and members of my team and others similarly situated are working hard to address this, because we're trying to understand, like, what are the obstacles. Now, to be totally fair, right, that study, as you appropriately noted, started looking at patients who were back in 2013 up to the 2020s, and so the guidelines in 2013 clearly were not as advanced as they are today, and Dr. Curry et al. Did note that there was an upward slope to the uptake of testing across that time period. So there was gradual improvement across many of those cancer types. They did also note that there was improvement, but there was somewhat slower improvement and somewhat less uptake, unfortunately, among patients from historically underrepresented and understudied populations, which is also a challenge, needless to say, in terms of access to, again, all of these advances in medicine. So what I have found is one of the outputs, the beneficial outputs of a lot of the research that we have been doing and we continue to do. In fact, for example, right, we're in the middle of a study right now that is focused on the implementation of universal germline genetic testing in patients with any kind of cancer, any kind of solid tumor cancer, in a community setting. It's
That's awesome.
being done in collaboration with Dr. Kashyap Patel. He's out in South Carolina, and the catchment area of his patient population is, if I recall correctly, it's around 60%, Northern European, about 20 or 30% self-reported African American, Hispanic and Asian in there as well. But it's in this community setting where we are working to demonstrate that it's not only feasible, but it's making, again, a difference in how these patients are being treated,
That's
and
huge.
and how the utilization of genetic information in the form of germline genetic testing changes and improves their outcomes. I'll also give a shout out to Dr. Shelton, Outer Banks Hospital, again, a community hospital out on the East Coast. And as soon as the American Society for Breast Surgeons came out with their newest guidelines, again, back in 2019, 2020, recommending universal germline genetic testing for all patients with breast cancer, he set about to implement that at his hospital, at his community hospital. And he has done that very effectively. And in fact, we were able to collaborate with him on just looking at some of the data that he's generated over the course of over 200 patients with breast cancer that he has seen, and he effectively implemented that. He's had the support of a genetics trained nurse practitioner out there, and they have done a remarkable job of getting well over 90% of the patients who have breast cancer genetic testing, right? There are some folks who choose not to do it, but the vast majority want that information, want that to be in the hands of their treating physicians. That has made a difference in how they are choosing their surgical approach. There was I think 20% of those individuals who tested negative, who changed their minds and chose to pursue a breast conserving surgical approach as opposed to a bilateral mastectomy as a risk reducing intervention, when they found that they did not have the increased risk that BRCA1 and BRCA2 confirm. And I think, to your point, the community clinics and the physicians and other clinicians taking care of patients in these clinics, they have a lot of responsibility. They have a lot of things that they're needing to deal with. And one of the biggest challenges that we face is helping to increase awareness among these these physicians and other clinicians that are the boots on the ground, that are taking care of patients on Main Street, that are taking care of the vast majority of cancer patients and other patients with rare disease, helping make it easier for them to know what the current recommendations are, and equally importantly, making it easier for them to implement germline testing for all the patients who qualify, without placing an additional burden on them in their busy practices, which is what many are concerned that this represents, is one more thing they need to do, and they've already got a list of a lot of things that they feel challenged to be able to meet in terms of providing the best care to their patients, which is of course their intent. And I'll tag that on to say there is also opportunity for increasing awareness and education, not only among treating physicians but among patients.
Okay.
Patients are, as you well know, and I think as your effort here clearly embodies, the best advocates for themselves and their health. And as a treating physician, not an oncologist, but as an internist and as a clinical geneticist, I appreciate having patients bring to me things that they have read about, questions that they have, asking me if a particular test or if a particular approach is something that's appropriate to them, because I'll do my best to keep up with everything in the literature, but patients become experts with their own condition very quickly, I think, out of necessity, unfortunately. And it's an opportunity for both us as the genetics community to raise the awareness of and educate patients about the importance of germline genetic testing for patients with cancer across the board, for patients with rare diseases like epilepsy, like cardiomyopathy, like high cholesterol, autism, developmental delay and disability, and help them to prompt their physicians, to ask their physicians about genetic testing, especially in those cases where there are clear guidelines and clear evidence that support this. And the last thing I'll note about this is, you've already touched on it, right? Clearly, we need insurance policies to be updated to incorporate all of this evidence that has been accruing, the recommendations that changing on a regular basis and being updated on a regular basis in support of genetic testing. And I will call out what unfortunately is an unusual example, but kudos to this particular example. This is an example of uh, a very up-to-date and evidence-based medical policy for germline genetic testing in patients with colorectal cancer. This is the policy of United Healthcare. I think it's the largest commercial insurer in the United States. They put this policy into place back in 2020, and their policy supports, as medically necessary, germline genetic testing for every person who is diagnosed with colorectal cancer. And it doesn't stop there. It's medically necessary under their policy, and their policy supports testing of every individual who is diagnosed with any cancer that is associated with Lynch syndrome, which includes uterine cancer, which includes thyroid cancer, which includes small bowel, long list of cancer types. They put that policy into place, and that's the kind of thing that we need to see happening across other insurers. And also, we need physicians and patients to know, for example, if you're covered by United Healthcare, make sure you're getting testing if you have colon cancer or if you have uterine cancer, because it's a covered benefit. We did a study a little bit ago, just looking retrospectively at patients who were covered by United Healthcare. And we found that in spite of the fact that that universal coverage policy is in place, less than 10% of all the patients covered by United Healthcare who had a diagnosis of colorectal cancer received germline genetic testing. And it was a covered benefit for them for which they qualified. And that's where we have an opportunity to, again, educate clinicians, educate patients to avail themselves of what is clinically recommended based upon the guidelines and the medical evidence, and what is supported by an insurance policy as well.
Gosh, that's so good. Dr. Esplin, I really, really appreciate you being generous with your time and giving this information to our listeners and those who are watching this, because this is extremely valuable. For those of you who might be listening via different social media platforms, you can go to geneticsforhealthcare.com and subscribe so you can get these new episodes delivered to your inbox. We're going to make sure we clip what you just said about that medical policy, because it really is about patient access. We've been discussing the challenges that came since you were in training to conceptualize what can be done, and the doing part you've been committed to with an incredible team of scientists and professionals to get these products to the market, and with evidence, proof of clinical utility, and where payers will pay for it. And they are, and we still see through different surveys, studies, and real world examples that we've had here, even on, Genetics for Healthcare, this podcast, that patients aren't getting them. So I love to end by asking our guests for 3 practical tips. Now, this is not a medical advice show, but I appreciate having Dr. Esplin on, who can read from medical policy, because that's his job, to read and to inform medical policy. But Dr. Esplin, for those who are out there who may be thinking about germline genetic testing, whether it is for cancer diagnosis, or they battle epilepsy, or any number of diseases, what tips can you give them to help support them and advocate for themselves, to give them the language and possibly the confidence to advocate for themselves, to go talk about this and request this from their medical providers?
Absolutely. Now, I could talk about this for a long time, but I will keep it as concise as I can. And some of this will sound similar to what I've noted before, but I'll condense it here. So, all patients with cancer should ask their physicians for germline genetic testing. If their physician hesitates or dismisses it as unnecessary, keep asking.
Mm.
This can open opportunities for cutting edge effective treatments that will not be accessible to you otherwise, whether FDA approved therapies or in the context of clinical trials. And as we get better at treating cancer, this is also crucial to identify genetic cancer risks so that patients who successfully beat cancer do not go on to develop a new preventable cancer. We did a study just a couple of years ago, and we found that almost 10% of the patients that we had seen for testing, for germline testing, had only received that germline testing after they had developed a second cancer. And if the testing had occurred at the diagnosis of their first cancer, many of them could have known to engage preventive screenings or preventive interventions to at the least mitigate their risk of the future cancer or completely eliminate the risk of that future cancer ever taking place. That's number one. Number two, all patients with epilepsy, cardiomyopathy, high cholesterol, autism, or developmental delay disability should ask their physicians for germline testing and keep asking. The evidence is there. The guidelines support it. And this also can open opportunities for effective treatments and will also help accelerate the development of new therapies for patients with diseases that are individually rare, but they are common in aggregate. And three, for those who are looking for reliable information about cancer syndromes, about other rare diseases and other syndromes, I highly recommend genereviews.org. It's a reliable source. It's better than just Googling your condition. And it's a source that is peer reviewed. It is updated on a regular basis by genetics professionals and other clinical professionals that are specialists in their field. And it can provide a great deal of information about both the genetics of these conditions, about how they are diagnosed, uh, about prognosis information, and importantly, about treatment and potential clinical trial information as well. That's genereviews.org. Again, obviously, it's a nonprofit, but I reference it frequently, and as a practicing clinical geneticist, I routinely recommend it to and point my patients to it as well, because it has information that I will also say is not just, it's good for clinicians. I mean, it's definitely good for clinicians too, but it's also, I believe, written in a way that is as accessible as any medical literature can be for patients and other folks who don't read this stuff all the time.